Hi guys, Dr. Ryan here. Hope you and your folks are well. Today we're breaking down stroke. Alright, if you haven't yet subscribed to my channel, what are you waiting for? I'm a board certified internist and let's get it started, guys. Stroke. There's 27 causes of stroke can be certified into hemorrhagic and ischemic etiologies. Now, stroke essentially is a vascular insult to the brain that results in permanent focal neurological deficit. Hemorrhagic is further stratified into intracerebral, there's 10 causes. Subarachnoid, there's 3 causes. Ischemic is further stratified into in situ occlusion, there's 9 causes. Embolism with 3 causes. Watershed with 2 causes. In situ occlusion, we further separate into that which is large vessel and small vessel in etiology. So hemorrhagic strokes, guys, there's a whole lot of intracerebral causes. Hypertension, especially in the setting of hypertensive emergency. Those patients often come in with encephalopathy and seizures. Cerebral amyloid angioplasty, head trauma, bleeding diathesis from whatever cause, congenital vascular malformation, brain tumor, all right, aneurysm, right, especially Berry aneurysms in autosomal polycystic kidney disease, cerebral venous thrombosis, right, moya, and hemorrhagic transformation of an infarct. Subarachnoid causes of hemorrhage can be due to trauma, aneurysm, and the perimesencephalic non-aneurysmal flavor of subarachnoid hemorrhage. In situ ischemic occlusion, if it's large vessel, usually on the back of atherosclerosis, and there we think of our traditional cardiovascular risk factors. Did the patient have a previous stroke or a previous MI? Is the patient hypertensive or diabetic or have hypercholesterolemia? Is the patient smoking? Is there a family history? Those things. Then you talk about dissection, vasoconstriction, fibromuscular dysplasia, vasculitis, like things like, you have classic vasculitic syndromes, not forgetting primary CNS vasculitis, moya, and bleeding disorder. What causes in situ small vessel ischemia is lipohydrosis, which gives you so-called lacuna subcortical infarcts, usually due to lipohydrosis due to chronic hypertension. Then atherosclerosis can also cause it. Embolism, where the clot is coming from elsewhere and shooting up to the brain. Classic example is cardioembolism from a patient who has atrial fibrillation or left ventricular thrombus or infective endocarditis. Artery to artery could be coming from the carotids and shooting up to the cerebrum, right? And hence the importance, this underpins the importance of doing a carotid Doppler in such patients. Paradoxical means it comes from the right to the left side of the heart, usually via a patent foramen ovale or some kind of connection, could be a patent ductus arteriosus, and then the clot goes up to the brain. Watershed infarcts or, guys, systemic hypotension, diffuse atherosclerosis, right? Guys, here's our immediate management of stroke patients. So you know the mnemonic FAST, right, or the acronym FAST, which is face, arm, speech, and time. If there's hemifacial droop, there's weakness in one side of the body, you find that the patient can't speak, they have slurred speech, then you got to be quick. Get that patient through to your nearest hospital or care facility, right? So important interventions at hospital arrival should occur within 10 minutes of arrival. Neurological assessment and stroke team evaluation usually within 20 minutes of arrival. You should have your head CT scan as far as possible within 20 minutes of arrival and have an interpretation of that CT brain within 45 minutes. Now, if that CT confirms that you got a head bleed, unfortunately, we can't thrombolize that patient. You got to activate the intracranial hemorrhage protocol, and it needs to be discussed with neurosurgery with a view to clot evaluation, depending on the territory and the size of the hemorrhage. But if there is no head bleed, right, then you can consider this being possibly ischemic stroke. You may consider fibrinolytic therapy if the patient presents within at least maximum 4.5 hours from the time of onset of symptoms, right? If they do qualify for fibrinolysis, and there's a whole lot of contraindications to thrombolysis, right? If there's no contraindications, we can give recombinant tissue plasminogen activator within 60 minutes, right? And then you can consider endovascular thrombectomy, right? That's essentially our management. And then from that point onwards, it's about rehabilitation of the patient, occupational therapy, physiotherapy, speech therapy, and of course, prevention of complications like deep vein thrombi and hypostatic pneumonia. And you got to get fluids and feeds into the patient, right? If they can't swallow nasogastric tube, etc., DVT prophylaxis. But in terms of secondary prevention going forward, we talk about A, B, C, D, E, F, G. So A speaks to a dual antiplatelets, usually aspirin, or you can give clopidogrel if it's a recurrent stroke, or ACE inhibition, which is good because it's antiproteinuric as well as hypertensive. Blood pressure control, usually we aim for a systolic below 140, diastolic below 90. But if the patient is diabetic with chronic kidney disease, that target is now less than 130/80. Cholesterol control, we aim for a total cholesterol of below 4.5. Low density lipoprotein LDL below 1.8, triglycerides below 1.7, HDL at least above 1 in males and females rather, and above 1.2 in males. That's millimole per liter. In terms of diabetes control, your glycemic control, we aim for the HbA1c and glycated hemoglobin below 7. Fasting or a preprandial glucose of between 4 and 7 millimole per liter, and a postprandial or a random value between 5 to 10 millimole per liter. Exercise is moderate intensity aerobic physical exercise for at least 30 minutes for at least 3 to 5 days per week. Fat reduction, so you aim to decrease central adiposity and get to quit smoking. There you are, guys. Hope you enjoyed this. Love you so much. Thank you for joining my channel, and I will see you soon with another handy rapid review in internal medicine. God bless you.